To begin with, we have Dr. NEENA R. She's the head of Pediatric Opthal in Giridhar Eye Institute. Over to you, ma'am.
Thank you, Sugranjini, and Sugranjini is always up to date, and it's a pleasure to be with her in this interesting IC. So I'll be talking about what's new in pediatric ophthalmology. So the paradigm one would be the change in the way we care about children. Now, pediatric ophthalmology is no longer something that general ophthalmologists do as a part of their majorly adult clinical practice. It is definitely a super specialty or a specific subspecialty now, and we have child-focused dedicated pediatric ophthalmology clinics with pediatric ophthalmologists, optometrists, orthoptists, and nurses. So the target or the thrust is to provide facilities which are specifically pitched towards children with experienced staff and appropriate safeguarding and training. The second paradigm would be how we look at myopia management. The focus now is not just on giving glasses and treating myopia. The focus is on controlling progressive myopia. So with our new understanding of the genetic risk factors and understanding how the visual environment influences myopia, with pharmacological options like low-dose atropine and optical options, we have a lot of things to do in the management of progressive myopia. So the visual environment modifications would be to reduce the screen times and sustained near work and to increase the outdoor time in sun. This is the norm that we follow now. And pharmacological options, low-dose atropine is already here, and probably what's going to happen is we're going to come up with the optimum concentration which is going to help us in attaining the myopia control. So Indian experience is also ample, and we've also tried this. The 0.05 concentration is soon going to be available in India, and that would be a new tool in our armamentarium. So the optical options, they are also available right now, especially the peripheral defocus spectacle lenses. So our understanding is that, you have a traditional correction which only corrects the center, and in fact, it produces a hyperopic defocus in the periphery, which acts like a stimulus for further axial length elongation, and that is the reason why the myopes continue to be progressing despite on an optimal glasses. So the aim is now to produce myopic defocus in the periphery so that the axial length elongation is prevented. So with this thought in mind, various prototypes are there. The first one was the DIMS lenses, or diffuse incorporated multiple segment lenses, which is currently the Hoya Mio Smart one is available in India. Then you have the Essilor's HALT technology, which is based on highly aspherical lenslet targets, which produces a volume of myopic defocus in the periphery. And then you have the latest, the Zeiss MyoK lenses, the CARE lenses, central annular refractive elements, which again focuses to provide a myopic defocus in the periphery. The new kid on the block would be the DOT lenses, diffusion optics technology. Now this thing's slightly different. So what they found was that when you have abnormally high retinal contrast signals, this was a stimulus for progressive myopia. So if you can reduce this contrast, it can slow down axial length. So they have incorporated thousands of microdots in the lenses, which is kind of doing the same function. It's not available in India yet. Contact lenses for myopia control are very much available abroad, but not in India, starting from the bifocal to the multifocal. So various prototypes are here, from Cooper Vision to Johnson & Johnson. These are not yet available in India. They also have the EDOF lenses, that is the extended depth of focused contact lenses, which again works on manipulating the higher order aberrations and reducing the contrast in the retina and slowing down the axial length elongation, not yet available in India. So there is a lot of exciting new vistas in myopia control on the way. Some new things which are being investigated now are low-level red light therapy, which says if you have a low-level exposure to red light of 650 nanometer, it was able to control myopia, but not been validated yet. Then you have virtual reality-based visual training, with which virtual reality headsets you're able to provide a visual environment which simulates outdoor activity. So that's going to be something new. Then ATOM3 is on the way in Singapore National Eye Center, which aims to prevent myopia even before it starts. Can you give it to pre-myopes and prevent myopia? That's what ATOM3 is looking at. And of course, studying the genetic polymorphism and using it in a positive way to control the myopia progression would be the last thing that we would like to look into. Paradigm 3 would be advances in the imaging and diagnosis like handheld OCT. You can see what are the applications right from cornea to retina to neurophthal to intraocular tumors management. Handheld OCT is a very big, invention which has changed the way. Of course, advances in IOP recording like the use of eye care tonometer, especially the eye care rebound tonometer, which you can use both in the prone and supine position, has reduced the number of EUAs we do for children, the children who need a regular intraocular pressure measurements, because it requires minimal cooperation, no drops, and it's quite fast. And you get a reliable reading, so you can avoid the EUAs. Paradigm 4 would be the development in preschool vision screening. It's a big challenge to screen these children without cycloplegic retinoscopy. How do you know what's accurate? So autorefractive screening, photo screening, and VP-based screening is here. And we also have used this. So this is a Welch-Allen spot vision screener, which we use widely for screening children. It is calibrated as per the APOS guidelines and picks up amblyogenic risk factors, and it's quite sensitive. So paradigm 5 would be the new developments in amblyopia treatment. So thrust is now not for monocular occlusion but for binocular therapy and improving the binocular vision. So we have various modalities like liquid crystal glasses, which uses an intermittent flickering shutter, so it can switch on and switch off between the amblyopic eye and give us some sort of binocularity as well as a monocular occlusion. Then you have revital vision, which is based on perceptual learning, based on the Gabor-Poch concept, and binocular therapy with like Binox and IBIT and dichoptic therapy. So these are some new things. Due to shortage of time, I won't be going into details. Paradigm 6 would be minimally invasive strabismus surgery using keyhole openings to do strabismus surgery instead of large openings. Difficult but achievable. Paradigm 7 would be readily available genetic testing. This has really changed the way we look at complex ophthalmic disorders or complex eye diseases which are inherited in children. And so with the new diagnostic modalities for deep phenotyping, combined with the genomic testing, we are able to come to diagnosis of complex inherited conditions, especially retinal diseases. And we are also doing it now, and we have promising discoveries like the Luxturna for RP65LCA, the CRISPR gene editing version for CEP299LC is already there, and the antisense oligonucleotide-based therapy is also there. Thank you very much.
Thank you for that excellent talk, ma'am. If I could ask you, among all this array of recent advances, what is exactly available for us at our disposal in Kerala specifically, or in our institute? Like, what do you feel?
Yeah, so all these we are doing most of the things. That's why I mentioned, like we have specific pediatric ophthalmology clinics now. Myopia control is, everybody is aware that we need to control, so we have optical aids like the peripheral defocus lenses are available. The DIMS, the HALT, the MyoK lenses are there, but the contact lenses are not available in India. The EDOF lenses also not available. The DOT lenses are also not available. Low-dose atropine has been there for a very long time. Then amblyopia management, the binocular therapy, we have Revital Vision in our hospital. A lot of other places have Binox. And the other ones are probably available on a smaller scale, but some of them are still in experimental stage. Genetic testing has become very, very affordable now, and we are using it. And the minimally invasive surgeries are yet to pick up because it's technically more challenging, but probably doable in the long way.